Good evening, everyone, and welcome to the Science Behind the Stove. I'm Denise Kolovoski, the Executive Director of the MSUD Family Support Group. Thank you for being here tonight as we bring together MSUD and HCU communities to explore how the science and nutrition support daily health and well-being. We extend our appreciation to the HCU Network America for co-hosting this program, and our sponsors, Cambrooke, Nutricia, and VitaFlow for their continued support. And now I'm pleased to turn over the program to Danae Barque, the Executive Director of the HCU Network America. Danae?
Hi, everyone. Thank you, Denise, and welcome to everyone joining us this evening. I'm just going to set the stage here really quick, the goals of this evening. By the end of our presentation, participants will understand how participating in a patient registry can lead to improved treatments and outcomes. Participants will hear what we have learned about HCU and MSUD through patient registries and natural history studies, and participants will enjoy learning new cooking techniques. And so again, thank you to our sponsors for this evening and our partnership with HCU Network America and MSUD Family Support. And we are excited to have a great program planned for you tonight. It includes a presentation from Dr. Josh Baker, and it highlights both the commonalities of the HCU and MSUD registries in a live cooking demonstration. Please feel free to have your questions ready. There's time in the agenda for a Q&A. You can type them into the chat during the time or unmute yourself to ask them directly. We begin by hearing from Dr. Josh Baker, who will share how science and clinical data drive advances in dietary therapy and patient care for individuals with MSUD and HCU.
Well, thank you, Danae. I'm pleased to introduce Dr. Joshua Baker. Dr. Baker is a clinical biochemist, geneticist at Ann and Robert H. Lurie Children's Hospital of Chicago and an assistant professor of pediatrics at Northwestern University Feinberg School of Medicine. He is also board certified in biomedical genetics and works closely with individuals living with MSUD and classical HCU. He also serves on the MSUD's Science Advisory Board and as a medical advisor to the HCU Network America. His active research includes participation in multiple clinical trials and efforts to better understand how the social determinants of health impact metabolic families. I'm pleased to welcome Dr. Josh Baker.
Thank you, Denise and Danae and Karen, for having me. And thank you for that nice welcome introduction. That seems to make me much more sort of bigger than I sound, but I'm happy to really talk to you all tonight and excited to sort of get to talk to you about something outside of the clinic space. So what I'm taking the time to talk to you about for a few minutes tonight is longitudinal data, or some may also call it natural history data. So what is longitudinal data? We're looking at an individual over time. That information for one person actually brings us a lot of data and information, but can even be stronger with many, many more people over time. There's different ways you can look at longitudinal data. There's the way of looking back in the chart, retrospective, but actually the much more data that we can get is if we looked at something prospective. So look at an individual over time because we can ask questions and learn more information as we go. As you can probably imagine, either looking through chart or surveys, trying to look back in time is limited based on what was provided in that documentation. What can you recall about those events, those different series? We're not great people at keeping records for these individual aspects, but if you ask someone in that moment in time, we can get a lot of detailed information as we move forward. And that sort of aspect is really important in looking at these inborn errors of metabolism to see what is that impact to that individual What's that change that's then happening if we try to then alter what that natural history is? I think I heard recently, if any of you know Dr. Carrie Harding, the goal of natural history is to then change natural history, make it unnatural anymore because we want to change that disease progress. And luckily, we've done that already for many inborn errors of metabolism, but we're not done. We're going to keep moving forward and changing lives. So why is longitudinal data important? I sort of talked about this a little bit more, but really knowing researchers, clinicians, and even patients and families to know what is that life like over time, and then how can we make adjustments or learn from that information. Unfortunately, the realistic aspect of getting any medication, any sort of study or different design changed or approved in the US is you have to prove to the FDA or different regulation agencies if you're outside of the US on does that change make a meaningful impact to that patient and in a safe way. So we can't know if we're making a good impact or changing that disease process without knowing what is that life like for that individual on our current treatment and standards. What does life look like? What are those complications that still happen? And then how can we impact or change that? That's important for finding new treatments, developing new technologies, and especially trying to find a cure. I think that the aspect of current longitudinal data, we need to sort of really dive in making sure that the data we're collecting is diverse and it represents all patients with the conditions. Historically, there are certain populations that participate in this longitudinal data, but we need to know what it looks like for everyone from every background so that we can properly sort of make that impact and help benefit everybody with these conditions. And like I sort of mentioned, we are already doing this, luckily. And this is some data that I have not been a part of, but have been a part of now through the different sort of organizations, classical HCU and MSUD. Overall, I think some aspects here that we're still learning a lot, that we'll go through some of these individual aspects, and then some things that we're still learning. So if we start with HCU, we know that patients diagnosed with newborn screen who are on treatment right away have better outcomes. That's something that we've learned from longitudinal data and from registries. It makes sense, right? Early treatment, early diagnosis means better outcomes. But to have that formally sort of written out and proven is really important to show regulators, show other clinicians how important newborn screening is, how important early treatment is, because otherwise we may not know. It would be fine to wait and treat until later, or a company may say, we're not going to approve this drug until a certain age, but we know now we need to diagnose and treat younger and younger if possible. We also know different patients have different sort of variants or different changes in the gene that lead to different outcomes. One is the vitamin B6 responsiveness. And actually, we're able now, because of longitudinal data, to know that some patients who respond to B6, we can then switch them to sort of a different path and have a vitamin first approach, while others, based on their genetic information or their trials to B6, we need to switch them to a low protein medical formula very quickly to make sure that we bring those homocysteine levels in a safe range. And then some concrete data, some actual numbers. Without treatment by age 10, 55% of vitamin B6 responsive, and then 82% of non-responsive will have lens dislocation without treatment. So that's giving us actual numbers. If we don't change the natural history, what is that I've changed? What are those ocular risks if we're not treated? So we need to treat before 10 years of age and prevent that complication. Without treatment by 15 years of age, 12% of vitamin B6 responsive patients and 27% of non-responsive individuals will have thrombolytic events. This means a stroke, some sort of other blood clot. So by age 15 is quite important then that we are diagnosing, treating much younger that. As you can probably imagine, those individuals who have unfortunately had a stroke, some sort of blood clot event, that can be devastating and life-changing. So let's prevent that complication before we can. For MSUD, we know from longitudinal data that infection is the most common cause of metabolic decompensation. I think that that's also important to show because infections, unfortunately, can't prevent every infection, but we can look at early sort of metabolic emergency letters, guidelines to say, how do we respond when someone has an infection? It's also important to know because without this data, people could guess what the most common decompensation is. We're going to talk about food and formula in a little bit, but I think that some would sort of argue what people eat might have been the most common cause for decompensation. I do think that that probably was the natural history at one point, but we've changed that. I think that we have gotten much better about early diagnosis, early treatment with formula and medical food to change that leucine level for these individuals. Patients diagnosed and treated before metabolic decompensation have better outcomes. Again, you're going to hear me say this over and over again whenever you hear me speak. Early diagnosis, early treatment means better outcomes. So I want to find everybody as soon as possible so that we can have the best outcomes for these individuals. The third, branch chain amino acid levels remain elevated 1.5 to 2 times the upper limit normal even post-transplant. I think this is fascinating. We don't know why this happens, but that's important for us to know that we don't need to sort of hit a panic mode when leucine branch chains are that high after a transplant because the transplant doesn't mean it failed. We just know that there are higher levels still present, even on a new liver that's processing that leucine. And then the incidence of depression, anxiety, and panic disorder is greater in patients with MSUD than the general population and even among siblings. So we're taking individuals from the same home and finding that information. This is really important too, because the leucine levels are in this condition are having a direct impact on sort of neurocognitive aspects, that quality of life. And we need to recognize that we need to treat that better so that we can have individuals taking care of themselves and their condition. Overall, both conditions, as you know, you're on a sort of webinar talking about the science behind the diet, is really important from this data to know that we know that these modified medical formulas, these modified diets, are going to look different for every person, but each and every one of them have been designed and evaluated by researchers, by clinicians, and most importantly, by dietitians to help sort of evaluate and change this natural history of both of these conditions. But without continued information and continued changes, we don't know how we're altering, changing the natural history, the longitudinal data to make things better for individuals and better outcomes for all. I think that's the end of my part, but I will stay on and I'll stay muted. I'm happy to answer any questions or comments that people have when we get to the question and answer section.
Great. Well, thank you, Dr. Baker, for such an informative and engaging presentation. Your work continues to guide our understanding of how science and data can truly shape better outcomes for families living with MSUD and HCU. And just a reminder, there'll be time later in the agenda for the questions and answers, but you can enter them anytime in the chat, or later on, you can always unmute yourself to ask them directly. And now we'll shift focus to the next portion of our program, an inside look into the patient registries that make research like this possible. I'm honored to introduce Dr. Karen Dollins, Research Lead for the MSUD Family Support Group, our Board Secretary and mom of Hannah, an adult living with MSUD. Dr. Dollins has been instrumental in advancing the MSUD registry and strengthening collaborations across the research community. It's my pleasure to introduce Dr. Karen Dollins.
Thank you, Denise. So I have 5 minutes to tell you a little bit about the MSUD registry. Hopefully everyone here who is with the MSUD community is aware of our registry. We really do try to send out mailings, emailings, e-blasts. It's in the newsletter with every issue, and we also post it on social media. If you go to our website, you can also find a registry page. So our MSUD registry is housed by an organization called Coordination of Rare Diseases at Sanford, or CORDS. And they're an international patient registry. They house the registries for over 1,000 different rare diseases. And so they are really unique in that they've been able to bring us as patients and advocacy groups together with researchers to help identify areas that need research and then provide them with baseline information that they might use to carry out that research. We are very fortunate in that there is no charge to us to house the registry. Next. If you do go to our website, you'll notice that there are 3 steps to this registry. The first step is simply the registration. You are registering with the CORDS organization. And that's where you're giving them your baseline information, your name, your address, just very general information. The next step is to go to the CORDS general questionnaire. So they're going to ask you very general questions. They're going to ask you things like your age, your date of birth, your gender, did you have newborn screening, things that actually apply to all the different diseases that they are responsible for within their larger registry. And then finally, the third step is the MSUD specific questionnaire. That's the one that we wrote in coordination with our advisors and that we've designed to try to get a handle on just what it is like to live with MSUD. Next. If you go to the website, again, this is what you will see. The first item is what's called the activation form. You're just answering these very basic questions. Next. And I should say you can either do it for yourself if you're an adult, or you can do it as a caregiver on someone else's behalf. So once you have, can we go back, please? Thank you. Once you have completed that registration, you're going to see something that looks like this. You have completed the registry activation form, and it tells you that the next thing that you need to do is click on this link, set up your password, and then get information for how to proceed with the next 2 questionnaires. Next. So to date, we have 220 people enrolled in our registry. That is just phenomenal. So thank you to every one of you who have enrolled in our registry. Of the 220, though, only 120 have completed the MSUD questionnaire. And I say only, but 120 is a really good number. We're really thrilled with that. However, we do know that there are quite a few people who are stopping after that initial registration or after the general questionnaire and not going on to complete the MSUD specific questionnaire. And of course, that's what we really need to have people do. Dr. Baker was talking about longitudinal data, meaning we really want to know what life is like for people living with MSUD throughout their lifespan. So if a parent has enrolled the child in the first year or 2 of their life, we want further information all the way through childhood, adolescence, and into adulthood. We get questions all the time. Does anyone else have this experience? Has anyone else had that experience? And this registry is going to help us to answer those questions. So if you have completed the MSUD questionnaire, we thank you very much. If you're one of those who've provided an update, we appreciate it. But again, we're going to get the most value out of this if people are updating it annually. And you should be getting messaging from CORDS letting you know when it's time to provide that update. So here's the link that you can go to activate your form. That's just the registration. Remember, we want you to update your information every year. That's when it's going to be the most valuable to us, so we can really see what's going on with people as they go through the lifespan. We have a podcast as well that we did in conjunction with Cords, and that is on our website. So I hope you'll go and take a listen to that as well. And you can always ask us if you have any questions. Again, this information is on our website, and it's on the mailings that we send out to everyone. It's in the newsletter. It has my telephone number and email address, as well as the Cords access information. So please don't hesitate to reach out to either myself or Cords if you do have any questions about this process. Okay, I think that's it for me, and I'll turn it over to Danae.
Thank you, Dr. Dollins, for sharing those valuable updates on the MSUD registry and how this important data will help drive research forward. I will now share an overview of the HCU registry, which plays a similar role for the homocystinuria community. My name is Danae Barkey. I'm the Executive Director and co-founder of HCU Network America. And I work closely with our research coordinator, Brittany Park, who is in charge of the RareX data collection program, which is powered by RareX. And so by collecting and analyzing patient-reported data, the registry helps us better understand the long-term impact of HCU and identifies trends and supports the development of improved treatments and care strategies. So I'm going to share with you a little bit about RareX and kind of what this process looks like. So RareX is a nonprofit platform for collecting, structuring, and sharing data on rare diseases. They partner with patient advocacy groups like ours to make data collection accessible and easy for rare disease communities, ensuring that data is high quality, ready to be used to accelerate research and drive urgently needed treatments forward. There's a few simple steps to get you started if you have created an account. If you haven't created an account, first, you set up an account via rare-x.org/homocystinuria. You can see it up here on our screen. And then you're going to verify your account. You're going to go through an informed consent, fill out demographic, general information. Then you'll verify your data sharing agreement. And this allows you to decide who you want to share your data with. We do ask that you do share it with patient organizations like us, so we can actually help have informed conversations about our community. If you are a parent, you will fill out, you're going to have to go back in and then add your patient. And then after that is what we call a head to toe survey. It gives us a holistic overview of your bodily systems and the issues that you have faced. They may be related to HCU, they may not be, but it's important we have that better understanding overall. And then after you do that, you'll have the option to upload a genetic report. These are very important to helping us understand each phenotype. And then they will also be very important with the development of gene therapies. And so Dr. Baker talked a little bit about that in terms of diversity. And so that's really important to that aspect. And then after you complete the head to toe survey, it will also populate some additional surveys into your dashboard depending on your responses. Like the MSUD registry, we do ask that you go in annually and fill these out. And so this is what the platform dashboard will look like. After completing the head to toe survey, other surveys will pop up into your dashboard. And this section of the dashboard displays 2 points from a person's longitudinal data. And we ask, once you've completed the head to toe survey, you go back and update it as well as any other surveys on an annual basis. These are what create those longitudinal data points that Dr. Baker was speaking to. And then here's a little bit of information from our registry. We currently have 117 patients from 36 US states and 23 countries and counting. When we've shared this information with international researchers, they've been very impressed by the fact that we represent so many different communities around the globe with homocystinuria. So we continue to encourage everyone who has classical homocystinuria or one of the homocysteine related disorders to create an account. And then we break this down a little bit further. Of the 117, 78 of them have classical HCU, and 39 of them either have an intercellular cobalamin processing disorder or severe MTHFR. And like the issues that MSUD has with only so many people actually completing the survey, only about half of our patients, a little bit more than half, so 3/4, have completed the head to toe survey. It's really, we can't impress enough how important these are. We know you exist. That's what creating the account does, but it doesn't tell us what your problems are. We cannot begin to address your particular issues unless if you go complete those. And so we cannot impress that enough. So please go in and fill out those surveys and continue to update them. What we know so far from the 81 participants who have filled out their head to toe survey within the HCU data collection program is that 53 of those patients have vision issues, 48 have brain and nervous system, 40 of them, so about 50%, have digestive issues, and then just under 50% have bone, cartilage, and connective tissue issues, and about a third of them have sleep issues. And so we have a QR code here in the link to enroll. We do encourage anyone who has classical homocystinuria or a homocysteine related disorder to go in and create their account. And if you have one and you haven't looked in your dashboard recently, please go in and update it. We also have a podcast dedicated specifically to our community. And so it's the HCNU podcast. And each month, Ben, who is the host, interviews a different person who is, we highlight a domain each month. And so that domain from the survey, so if it's eyes, they speak to their issues with eyes. And so, or if it's the brain, then they speak to some of their cognitive issues or something like that. And so we have, I believe, over 30 episodes on there for you to choose from. So we have quite a few. And so, again, we can't encourage you enough. And I'm going to just do a little plug here. As a patient myself, the data that Dr. Baker shared came from a 1985 study. And I tell people this because that is the last natural history study we've had for the homocystinuria community. We are using data that is 40 years old, and we know the patient experience is different now than what it was. According to that data, I shouldn't be here. I shouldn't have a daughter, and we are achieving milestones that the data says we shouldn't. And we need to be able to rewrite those histories and to be able to help make it better for future generations. And the only way we can do that is by sharing our experiences. So I really, really encourage you to be part of changing the history for our communities. And with that is our question and answer time. So I'm going to stop sharing my screen, and then there are a few questions that have been submitted to the Q&A. And so I will ask those first. And then if you have any other questions, please enter them into the Q&A, or I think you should be able to raise your hand and I should be able to take you off mute. All right. So Dr. Baker, you're going to become a very popular person this evening. And so the questions are all for you. And maybe a few more will come in here. So
I can answer these as well, Danae.
Okay. It says, what health marker data do you consider important in life since child to adult?
For both disorders?
It says MSUD, but
yeah, let's do both though.
Yeah.
I think that's interesting because I do think that we do perseverate a lot on what our levels are in the clinic, but there's so much more than just that, right? Like I care for MSUD, your leucine level, for homocystinuria, what's your total homocysteine level, but there's so much more sort of in your body, that aspect. The dietitians were really important on what your nutrition is, what your bone health is doing. And I care a lot about what the quality of life markers are as well. Are you able to feel comfortable with your future career path? Are you able to feel comfortable with the lifestyle you want? Is there anything that's sort of hindering that because of both your condition or complications from your condition? I think that those are all reasons why we collect that data and want to improve that for all patients. Right now, we rely heavily on specific biochemical markers that are easy to collect in clinic to see how well someone's doing. But I do think we also need research with natural history to also do biobanking and do bio research to know better biomarkers to show what is that disease impact for some of these organ systems. I don't know if Karen, you have something else to add for MSUD? Oh, you're muted.
That's because my husband came into the room, so I muted myself. I told him I was on a webinar. Anyway, as Dr. Baker said, traditionally we've used leucine as the marker, but there's recognition not only by us, but also by the FDA that we need to look at more than just blood leucine levels. So we need to get a good sense, for example, of how many times a person is hospitalized. How well are they able to function? Do they need extra support in school? Are they able to hold down a job? Are they able to hold down a full-time job and live independently? So those are some of the questions that really get to quality of life and the burden of having these diseases that we also need to be collecting for people in order to move research forward.
And then the next question that we have is, what data sets are available for pattern research and exploration?
Yeah, I think that it's more that we need for both conditions and from both organizations. If we continue to put in data, we'll see more pattern recognition. I do think that's one aspect too, that AI might be a very useful tool moving forward in finding patterns that we can't really see easily and help us look at the data different ways. But at the end of the day, we need more data to find more patterns, and that's really what we need.
Dr. Dollins, do you have anything that you want to add with your expertise?
No, I know that the person asking is a person with MSUD. Hi, and I know that she's in Europe, so thank you for joining us. Um, again, we don't have enough data yet to be able to identify those patterns. So the more data we have, that's one of the hoped for outcomes is to be able to, as Dr. Baker said, perhaps even with the use of AI, identify those different patterns.
Yeah. And I think the next one is really important because we know that rare disease is rare, and each of these condition groups are rare too. And so the next question we have is, and I think we can explore this a little bit more past this question itself, but it says, do you work or have some collaboration with any organization or hospital in Mexico to track the longitudinal data of patients with MSUD? And Karen,
So I'll take that one. We have made huge efforts to reach out to the international community and both metabolic physicians and dietitians. And unfortunately, we've not been highly successful in getting a response from different countries. We do have an international reach, but it's not as great as we would like. We had translated our questionnaire into Spanish, but then we did make some revisions to the questionnaire. So we have to translate it again into Spanish because it doesn't, we can't use it anymore since we changed some of those questions. So thank you for asking that. It is a really, really important question because we really do need to understand what's going on in other parts of the world, and we're making a very big effort to try to capture that data.
Dr. Baker, do you have anything you want to add to global collaboration for registries?
No, I think that it is nice that I think that one benefit as we move towards sort of a global sort of community and world that we're all collaborative. We all sort of work at going through the international meetings. All it's hard to find someone in metabolism who doesn't know everybody else in metabolism, that we're trying to really grow and make that community small because we know that anyone with this condition feels completely alone. So let's bring everybody together with the aspects of working through anything like a Zoom that can bring people from across oceans together.
Yes. I think that's one of the things I find so inspiring when I have traveled to these international conferences he speaks about, because there might be 4,000 people there, which may seem like a lot, but the reality is that is for the entire globe. That's who's here to treat all patients with inborn errors of metabolism. And there's more than just HCU and MSUD. And so to think that those are the brilliant minds helping shape the future for all of us is really quite inspiring. And so I think it goes to show we definitely need to be working together closely to accelerate things for the patient community. And then we have a couple more questions, and I think we need to move on here. Denise, I'm going to let you be the moderator for time. But then we have, with the data you have received, how can we connect with locals with MSUD or a similar diagnosis? I don't know if Karen, that's something that you could.
Well, I'll just say that we cannot share information from the registries. It's what we call de-identified. So when we are looking at the actual data, the person's identifying information is not attached to that. However, that's what the MSUD Family Support Group does. So I know we don't have time to talk more about that, but otherwise I would turn it over to Denise to explain that a little bit more. But through things like webinars like this and our newsletter and our Facebook page, we do have lots of ways for people to do that. And I would encourage you maybe to connect with Denise, and she can give you more information about that.
And I'm just going to give a plug. Both HCU Network America and MSUD Family Support Group both have conferences in 2026.
Yes.
And that's a fantastic way to be able to network with other families and also try to pursue your different PKU and allied disorder local groups. I'm part of one here in Illinois covers PKU, HCU, MSUD, the whole gamut. And so there's quite a bit of support out there, but definitely connect with Denise and she can help give you those resources. Last one. How to know the perspectives for patients in adult life or older.
I think that's very similar to one of the previous questions, that we need the data to know. I think that right now we have anecdotal aspects at best, but we don't have true clean data to report out and state what that life looks like, and we need more data together. And I know that there's plenty of patients out there to help start that data collection, so we appreciate you all who have participated.
I apologize because I didn't see the last question, and this is the last one, and I know Karen's answered it.
I'm just yeah, because I
figured
we were running out of time.
Yes, to share.
And it's a complicated question.
Yeah, but if we could just, is there a way you can summarize it? So the questionnaire is, hold on. If the question was is a transplant the better option or is a low protein diet? And if there's a quick way to summarize that from either perspective.
And what I had said is that it's a very difficult question to answer, and different people have different opinions. But beyond that, I think I'll just kick it over to Dr. Baker and let him take that one.
Yeah, I do think that is also we need more data on. It's very different for each patient, what the family situation is, what the severity of disease is. But I do know that some of my sort of friends and colleagues, sort of like Jessica Gold, different people, are working at trying to answer that question. Look through charts, both retrospective and prospective to give a better answer of in 2025, 2026, what is the preferred method depending on specific genotype, specific enzymatic activity. But I think in 2025, it's still very much family preference is what is going to work best for individuals and your community and your team. It's going to be very different if you're in Chicago versus rural Illinois about what resources you have available, unfortunately. I wish that that was just the extent of it, but I think it goes even further when we look at the whole world, that there's different resources in every pocket, unfortunately. And Susan, I see your comment too. So hi, miss you in Boston.
I have one more comment for this actually, and I think this is one of the things Dr. Dollins and I have discussed too, is how do we activate the patient community that has had transplant, who is doing well. And the reality is, if you're doing well, your data and your experience is really important too. And so from the HCU side, we don't have transplants, but if you're doing well, we need to know that. We need to know what your experience has looked like so we can help other patients achieve what you have. And so having those points pulled into our data sets is critical to helping us understand how we get other patients to have healthy outcomes as well. And so that concludes our Q&A here. Thank you, Dr. Baker and Dr. Dollins. We are now going to turn over the program to our partners at Cambrooke for a low protein cooking demonstration, sharing practical techniques to support meal planning at home. And it is up to Bridget now. And we'll take a few final questions at the end. So please feel free to continue to enter those for Bridget as she goes about.
Hi, everyone. Thank you for having me. Tonight, I am going to demo something that we call thermos rice. It uses our short grain rice, which is great. And I think almost really one of my favorite things that Cambrooke has to offer. So if you've never made this before, all we use is a thermos, water, butter, salt, and hot water over time. So I will show you what it looks like. But basically, step one would be to fill up a thermos with boiling water, let it sit for 5 minutes, and then discard that water. And then that's a very important point, to heat up that thermos and get rid of it. And then when you're ready, you'll need another ½ cup of boiling water. I use a kettle, but having it be really hot is very key. So you would take the water, dump that in, 1/3 cup of measured short grain rice. You do not have to add butter, but personally, I think the butter makes it much better. So I'm gonna add a tablespoon of butter. Sorry, it's family dinner time here, but I'm sure it is for many of you. And then I like to add salt as well. And the key is to stir all that around and make sure it doesn't stick to the bottom. So make sure the rice is not sticky. Seal it. Shake it up. You'll hear that it's kind of sloshing around. And then it needs at least 2.5 hours to just sit. Don't touch it. Don't open it. Just let it sit. So this is a really great option for school for lunch. You could make it in the morning and it's perfect by lunch. So after 2.5 hours, and it can sit for longer than that, you'll hear, if you can hear that, it's totally solid. There's no sloshing, there's no water. Open it up, you can see that. It is some really good rice. So this is my favorite way to make our rice. It's delicious. It keeps very well. And it's like the perfect, maybe just over a cup serving. So super simple, super easy. This is my favorite way to make our rice. So I'm happy to answer any questions. I don't know if anyone's made this before, but it actually came from a PKU family in Chicago that taught us how to do this.
This one might be too specific for you. So the question here is, do you know if the Cambrooke products are available in Portugal?
Who I do not know, but if you put your information in the chat and Denise or Danae gets me that, can certainly get you the answer.
All right. I don't see any other questions, but I have a question for you. Are there other items from the Cambrooke line that can be made in the thermos for kind of easy, quick lunches, dinners for families on the go?
I have tried to do the pastas. Tried. They're just too delicate. So I have not found anything with rice. I provided a handout to Denise that can be shared. It doesn't have to be plain rice. This is a great base. You could throw veggies over it. But if you wanted to add about a half cup of vegetables to it, you certainly could. And that recipe page, we've got a red Thai curry with carrots in there. You know, our short grain rice, it comes from Japan, and it's really just pressed starch. So all we're doing is hydrating the rice over time, and it just makes it very tasty. So if you're going to add veggies, just make sure that they're already cooked or softened, sauteed. But yes, I've only been able to master the rice in the thermos, but it is one of my favorite things.
I part of the reason I asked, there was actually a conversation online recently about other things to do, and someone actually did find a trick for the thermos. And a protein pasta, they said they boiled water and put it into a thermos with the pasta, and after 8 minutes it was soft. But then you have to promptly drain and rinse. So
yes,
if you're in a pickle, you don't want to leave it sit though. So
that's good to know. I'm gonna have to try that out. You know, the only other way I've done it is to actually cook, the pasta before, and it's certainly you can use it in the thermos, but I will try that out and see how it goes.
Yes, I feel like this is where the power of the community really comes through. We're all looking for shortcuts and quote unquote hacks to make life easier and more efficient.
Yes, and so everyone who's on tonight, they're going to provide your information, and we will mail you one of the Cambrooke thermoses. Yours are going to be blue. So if you want to try this out, we're happy to support that. And like I said, one of our favorite things to use.
I do not see any more questions. Denise, I think it's over to you.
Okay, great. Well, thank you so much, Bridget. That was an exciting demonstration. We even had your puppy in the shot, which was fun.
It's real life with family in the background.
Yep. And that's what we're all here tonight, because that's our daily lives as well. So thank you so much, Bridget. That was awesome. We're so excited for our thermoses as well. So thank you to everyone, Danae, Dr. Baker, Dr. Gollins, and Bridget Tomic from Cambrooke for the information and tools that they all shared this evening with us. We're so grateful to Nutritia, VitaFlow, and Cambrooke for their continued sponsorship and support of the MSUD and HCU communities. And as a thank you for attending, as we mentioned, all participants receive a complimentary thermos from Cambrooke. You will receive additional information by email following the program about that. But before we close, we want to invite you to join us for the next free webinar called Fueling a Physically Active Lifestyle on a Low Protein Diet, presented by Dr. Karen Dollins on Thursday, December 11th at 6 p.m. Eastern. More information will be shared soon on our social media channels and through our e-blasts from both the MSUD Family Support Group and the HCU Network America. So everyone, thank you for spending the evening with us. We hope you had a great time and learned to navigate a little bit more about metabolic nutrition. Have a wonderful evening. Good night.